Acquired thrombotic disease. The majority of arterial thromboses relate to abnormal vessels, e.g. atheroma. Cellular blood components can increase total blood viscosity when present in excess, e.g. polycythemia, thrombocythemia and hyperleukocytosis. Similarly, increases in plasma viscosity, myeloma or Waldenström's macroglobulinemia, can produce cerebral, spinal, and cardiac ischemia. It is difficult to predict what level of plasma viscosity will cause problems because each individual will have a different threshold for symptoms and problems. Antiphospholipid antibody syndrome. NB. Pathophysiology. Virchow's triad states that three things should be considered in thrombosis: the vessel, the blood constituents and flow characteristics. Etiology. The antiphospholipid antibody syndrome, APAS, produces the paradox of prolonged clotting times but also an arterial and venous thrombotic tendency. This is because the antibody binds the phospholipid on the platelet surface and inhibits the clotting cascade from proceeding efficiently, prolonging the activated partial thromboplastin time, APTT, the lupus anticoagulant. At the same time, the antibody binds to thrombomodulin on endothelium and slows protein C activation, producing a prothrombotic tendency locally. It is now clear that the specificity of the antibody is for beta-2-glycoprotein 1, which in turn binds phospholipid, thereby acting as a natural anticoagulant. Epidemiology. Antiphospholipid antibodies are associated with inflammatory arthritis, e.g. refractory anemia and systemic lupus erythematosus, SLE. Acute infection, e.g. malaria and HIV. Thromboembolic vascular disease. Medication, e.g. phenothiazine and phenytoin. The majority of antibodies arise without any obvious predisposition. Note that antiphospholipid antibodies only occur in about 10% of patients with SLE. In unselected patients with these antibodies, 2.5% per year will develop thromboembolism. Clinical presentation. NB. The definition of APAS is the association of one or more clinical features with either the lupus anticoagulant or antiphospholipid antibodies tested on more than one occasion. Thromboembolism, venous greater than arterial. Recurrent fetal loss in the second or third trimester. The presence of IgG antiphospholipid antibodies confers a relative risk of 3.5. The placenta becomes infarcted and necrotic. Thrombocytopenia, platelet aggregation. Non-thrombotic central nervous system problems, chorea, epilepsy, and Guillain-Barré syndrome. Skin lesions, ulcers and livedo reticularis. Endocardial disease. Hemolytic anemia. Investigations. Full blood count. Check FBC for thrombocytopenia and a biochemical screen for renal impairment. Clotting studies. Antiphospholipid antibodies are detected by an enzyme-linked immunosorbent assay. It is likely that this will be superseded by beta-2-glycoprotein 1 assays in the future. A prolonged APTT may be a feature of, but is not specific for, APAS. Typically the APTT is not normalized by mixing with normal plasma. The dilute Russell's Viper venom test, DRVVT, is prolonged in APAS due to activation of the antibody blocking factor X by the venom. The DRVVT is expressed as a ratio of a patient's test to control, and the further step of adding excess platelets to swamp the effect of the antiphospholipid antibody and normalize the DRVVT confers even better specificity. Testing during anticoagulation is unreliable. Other tests: CXR and ECG to assess previous thrombotic episodes. NB. When considering APAS, both clotting and antibody tests should be repeated after an interval of 6 weeks for confirmation. Treatment: patients identified as having APAS should be referred to a specialist hematology clinic. Other risk factors for thromboembolism such as obesity, smoking, and the oral contraceptive should be reviewed and considered. Patients with deep vein thrombosis, DVT, or pulmonary embolism, PE, should be given heparin in the acute phase. The use of low molecular weight, LMW, heparin has removed the complexity of adjusting the heparin dose in the presence of an already abnormal APTT. A first event of DVT or PE should be treated with warfarin at a target INR of 2.5 and the duration of the therapy requires specialist assessment. A previous history of thromboembolism is an indication for long-term warfarin therapy, with a target INR of 2.5 if the recurrent DVT or PE occurred while the patient was off warfarin therapy, or a target INR of 3.5 for patients who develop a recurrence of DVT or PE while on warfarin at a lower target INR. For arterial thrombotic events, aspirin is insufficient therapy and a target INR of 3.5 is recommended as long as the bleeding risk at the higher intensity of anticoagulation is taken into consideration. Recurrent fetal loss is treated with LMW heparin and aspirin, preferably before conception. This is superior to steroid therapy. A positive antiphospholipid antibody or DRVVT with no clinical history is not an indication for anticoagulation. The patient should be kept under review.